Hello and welcome to this general medicine class on some miscellaneous endocrine topics like multiple endocrine neoplasia and autoimmune polyglandular syndrome. Hi, I am Dr. Sylvester Justin, Assistant Professor, Department of General Medicine, Sri Lakshmi Narayana Institute of Medical Sciences, Pondicherry. Let's get started with this general medicine class right away. So let's look at a couple of case histories. So in the first case, we have a 37-year-old man who presented to his GP with a 6-month history of diarrhea and abdominal pain. He was started on tablet pantoprazole 40 mg daily with good effect. 6 months later, he presented to the casualty with severe abdominal pain. He is pale and hypotensive. Blood results demonstrate anemia and mild hypercalcemia. Following diagnosis and surgical correction of a duodenal ulcer perforation, he is discharged home. Persisting hyperparathyroidism is detected on routine bloods by his GP. What is the diagnosis? So here we have a person who is having peptic ulcer disease, which is not getting corrected even with medical management, and he is having hyperparathyroidism as manifested by hypercalcemia. So this person is having what we say Zollinger-Ellison syndrome, which is nothing but gastrinoma, which causes peptic ulcer disease in multiple locations. This gastrinoma arises from pancreas. So this patient is having pancreatic tumor and hyperparathyroidism. Now this is a classical constellation which is seen in multiple endocrine neoplasia type 1. Let's go to the next case history. Here we have an 18-year-old woman presented to her GP after noticing a mass on the right side of her neck. An ultrasound demonstrates a solid ovoid to round, markedly hypoechoic nodule with internal microcalcifications. A fine needle aspiration biopsy is performed, and the results are suspicious for medullary thyroid carcinoma. She is referred to an endocrinologist who discovers an elevated parathyroid hormone level in addition to the expected elevated calcitonin level. So calcitonin levels are elevated in medullary thyroid carcinoma. Here, we also find the same patient having an elevated parathyroid hormone level, just like our previous patient. What is the diagnosis? So this constellation of findings is typical of men type 2 or 2A, multiple endocrine neoplasia type 2A. So what is multiple endocrine neoplasia? As the name suggests, it is a genetically determined constellation of endocrine neoplasms. So it is a clinically inherited syndrome involving neoplasia of different endocrine glands, each with its own characteristic pattern. In some cases, the tumors are malignant, in others, they are benign. Benign or malignant tumors of non-endocrine tissues also occur as components of some of these tumor syndromes. 3 different patterns of many syndromes can occur: MEN1, MEN2A, and MEN2B, with some new variants such as MEN4, which is considered a variant of MEN1, and the familial medullary thyroid cancer, FMTC, which is considered a variant of MEN2A. As you can see, there is no MEN3, so MEN2A is sometimes known only as MEN2, whereas 2B is known as MEN3. So this picture shows all the MEN syndromes at once. So we can see what are the main findings in MEN1. It's typically a triad of 3 tumors. One is a pituitary adenoma. Second is a parathyroid hyperplasia, which it has in common with MEN2 syndrome also. And third is a pancreatic tumor. As we can recall, our patient had a gastrinoma, which is a pancreatic tumor, and also a parathyroid hyperplasia as seen in blood tests as hypercalcemia. Men 2A, on the other hand, has again three main targets: parathyroid hyperplasia, medullary thyroid carcinoma. So both of these we have seen our case history too, and also pheochromocytoma, a tumor of the adrenals. Could be malignant or it could be benign also. There is something called as MEN2B. Here there are mucosal neuromas, marfanoid body habitus, and again medullary thyroid carcinoma and pheochromocytoma, just like MEN2A. In MEN2B, parathyroid hyperplasia is conspicuous by its absence. MEN1 is also known as Wermer syndrome. It is an autosomal dominant syndrome. Simultaneous neoplastic transformation of multiple endocrine tissues. As I said, typically PPP, right? The parathyroid glands, pancreatic islets, and anterior pituitary. This disorder is strongly suspected either in patients with endocrinopathies of at least two of the three main affected glands, that is parathyroid or enteropancreatic or pituitary tumor, or in patients with at least one endocrinopathy in one of these organs and a first degree relative who is affected by one of these tumors. So familial MEN1. So we saw that the inheritance is autosomal dominant. So a family history plus just one gland involvement is sufficient for us to suspect that it could be MEN in this patient also. Patients with features of MEN1 syndrome but without a family history of MEN1 are affected by a sporadic form of MEN1. So we cannot discount the diagnosis on the absence of a family history. MEN1 genetics. MEN1 is a tumor suppressor gene in chromosome 11, long arm and 13, and encodes for menin. These are the frequency of clinical features which are found in MEN1. In 100% of the patients, we will have parathyroid hyperplasia. On top of that, we may have gastroenteropancreatic tumors in 70 to 80%. Among these gastrinomas, as seen in our case history 1, are the most common ones. Non-functional are the next in order. Also, insulinomas, glucagonomas, VIPomas, and somatostatinomas may also be seen. Next in frequency are the anterior pituitary tumors. From 10 to even 60% of cases, we may see them. Among them, functioning tumors are much more common, and among them, prolactinoma is the commonest. Other variants are growth hormone or ACTHoma. Adrenal adenomas may also occur. Many of them are non-functional. Less than 1% are functional. And foregut carcinoids may also occur in about 10% of the patients. Apart from these, some non-endocrine tumors may also be seen, like angiofibromas, about 40 to 88% of the patients, and collagenomas, also some neurocutaneous markers like cafe au lait macules and lipomas. Central nervous system tumors may also be seen, like meningiomas, ependymomas, schwannoma, and also some muscle tumors, smooth muscle tumors like leiomyomas and leiomyosarcomas may also be seen. So here we can see on the skin there are some angiofibromas in the nose and facial region. Here we can see some collagenomas at the nape of the neck and abdomen in some patients. This is a cafe au lait macule, very easily identifiable by the way it's seen. So diagnosis of MEN1. So we have to consider testing for MEN1 in whenever there is a clinical criteria. When we saw in the previous slides that two or more of the three tumors are seen, or just one tumor and a first degree relative who is known to have MEN1. Also, any patient who is part of familial isolated hyperparathyroidism, in them also MEN1 can be suspected. Also, parathyroid hyperplasia or adenoma in less than 40 years of age, recurrent or multiglandular primary hyperparathyroidism at any age, gastrinoma or multifocal neuroendocrine tumor of the pancreas, or gastroduodenal-pancreatic neuroendocrine tumor of age in persons aged less than 40 years, or bronchial or thymic neuroendocrine tumors. So whenever these unusual tumors are found, we have to suspect that it could be MEN1 and we should go for testing. So this is some of the radiological findings seen in MEN type 1. In the first image, you can see the patient has undergone a scan, nuclear medicine sestamibi scan, and there it is showing a large avid nodule along the right tracheoesophageal groove marked by the arrow, black arrow. This is consistent with parathyroid adenoma. Also, in the CT scan in B, you have seen there is pancreatic tail neuroendocrine tumor as shown by the white arrow. And in the image C, we are seeing the MRI of the brain showing a pituitary adenoma. So this is the classical triad of parathyroid hyperplasia, pancreatic neuroendocrine tumor, and pituitary adenoma. The mortality of untreated MEN1 is high, with 50% of patients not living beyond age 50 years. The leading cause of death in MEN1 patients is the duodenal-pancreatic islet tumors, and the majority of MEN1 patients die of a process related to this disease. Coming next to MEN2. MEN2, formerly called as MEN2A, has a prevalence of 1 in 25,000 people. It is comprised of medullary thyroid carcinoma in 95% of patients, it's seen, and pheochromocytomas in about 50% of patients, and hyperparathyroidism in 20 to 30% of patients. Pheochromocytoma in MEN2 are rarely malignant, and prognosis in MEN2 is determined principally by the staging of medullary thyroid carcinoma. And there are some clinical variants of MEN2. In one, there can be cutaneous lichen amyloidosis, seen in 10% of families with MEN2. Hirschsprung disease, seen in about 7% of patients with MEN2. And there is familial MTC, that is familial medullary thyroid carcinoma, where they occur in isolation with no other involvement, no other gland involvement. It typically has a later age of onset. Thus, along with MEN2, there are 4 subtypes of MEN2. Okay, classical MEN2 and these 3 types: cutaneous lichen amyloidosis, Hirschsprung disease, and familial MTC. So this is showing cutaneous lichen amyloidosis in a patient. Here again, it is showing the clinical and histopathological pictures of cutaneous lichen amyloidosis. Especially in the pathological picture, we can see the bright pink color amyloid deposits. And this is showing the Hirschsprung disease, where there is disruption of the ganglion cell migration in the intestine. So the dilated part is the normal part, and the strictured part is the affected part. Coming to MEN3, this was formerly known as MEN2B. Prevalence is about 0.2 per 1 lakh. So it is very rare. MEN3 features include again medullary thyroid carcinoma and pheochromocytomas. In addition, newer things are Marfanoid habitus. Okay, the patient has a look as if he is having Marfan's tall and lean, that kind of look. Also, mucosal neuromas are seen and medulated corneal fibers are seen. But there is no hyperparathyroidism, which we saw in men 1 as well as men 2A or men 2 simply. So this is showing a person with men 2B. Here you can see in picture A, there is a female who is very thin and tall and lean, and this is a typical Marfanoid habitus, which is what we are referring to. In picture B, we are seeing some small tumors at the tip of the tongue. So these are the mucosal neuromas, and the eye sign includes the medulated corneal fibers, which will be better seen in slit lamp examination. Here again, in another case, we are seeing the mucosal neuromas in the tip of the tongue, and here in slit lamp, they are able to see the medulated corneal fibers. Men 3 is characterized by medullary thyroid carcinoma. Usually, this is the initial manifestation, and it is aggressive and early onset that typically presents in the first or second decade of life. Pheochromocytoma in up to 50% of men 3 patients is seen. Typical facial features including mucosal neuromas of the tongue, the lips and eyelid, and musculoskeletal deformities including a Marfanoid habitus, kyphoscoliosis, joint laxity, and bowing of extremities are often seen. Medulated corneal nerve fibers and ganglioneuromatosis of the gastrointestinal tract may also be seen. What is the genetics of men 2 and 3? So men 2, men 3 and familial medullary thyroid cancer are all caused by mutations in the red proto-oncogene located on the long arm of chromosome 10 at the focus 11.2. Screening for men 2 and men 3 is aimed at the early detection of medullary thyroid carcinoma and pheochromocytoma. Genetics testing of men 2 families and prophylactic thyroidectomy has replaced the use of pentagastrin stimulation testing in screening for medullary thyroid carcinoma. The timing of prophylactic thyroidectomy is genotype specific. Screening for pheochromocytoma in men 2 and men 3 is primarily through the periodic measurement of metanephrine and normetanephrine in either plasma or a 24-hour urine sample. Also, the patient may have clinically high episodes of high BP also. Adrenal imaging with CT or MRI may also help. And also the gallium dotatate PET imaging, where using this tracer molecule, we are able to look for the tumor in the adrenal gland. Coming to treatment, men 2 and men 3 patients who have been known to have red mutations require a prophylactic thyroidectomy, which is ideally before the MTC has developed. As we already saw, MTC decides the lifespan of this patient. If the MTC is picked up early, or if the chance of MTC itself is taken away by removal of thyroid glands, then that will give the best chance to the patient. Vanditanib, which is an oral inhibitor of RET, vascular endothelial growth factor receptor, and epidermal growth factor receptor signaling, is also used in this tumor. Also, cabozantinib, which is an oral inhibitor of MET, VEGFR, and RET, is also used in these tumors. The treatment of pheochromocytoma is surgical removal, which should be performed prior to thyroidectomy for medullary thyroid carcinoma. The reason for this is that unrecognized pheochromocytoma in surgery is associated with significant morbidity and mortality. There may be intraoperative spikes of hypertension, which may not be able to be managed well during the surgery, causing significant morbidity, and even it can lead to mortality. We want to avoid this situation, and that's why any patient with medullary thyroid carcinoma better to go for testing of urinary or plasma metanephrines and adrenal imaging to rule out a simultaneous pheochromocytoma. So these are the frequency of clinical features in MEN 2 and 3. Otherwise, MEN 2A and 2B. 2B is 3. Okay. So in MEN 2A, we have medullary thyroid carcinoma 100%, pheochromocytoma maybe up to 50%, and primary hyperparathyroidism is also seen. And of course, there are the other variants like cutaneous lichen amyloidosis and Hirschsprung disease. In MEN 2B, again, medullary thyroid carcinoma is 100%, pheochromocytoma up to 50%, and primary hyperparathyroidism is conspicuous by its absence. And there may be gastrointestinal tumors, ophthalmological, and skeletal manifestations like Marfan syndrome. So that is also seen in 100% of the patients. Coming to MEN 4, is this really an entity? It was reported first in 2006. In this, patients developed MEN 1 associated tumors, including parathyroid tumors and anterior pituitary tumors. These are associated with some tumors of non-endocrine organs like kidneys. Also, adrenals and reproductive organs may be affected. In MEN 1, we recall the triad is parathyroid tumors, pituitary tumors, and hyperparathyroidism. But here we are having kidney and adrenal tumors, which is rather seen in MEN 2, like pheochromocytoma, and also some reproductive organ tumors. So the gene identified is CDKN1B gene, located on chromosome 12, long arm. So that brings us to the end of discussion on multiple endocrine neoplasias. Let's also have a small look at autoimmune polyglandular syndromes, which are equally, if not more rare than the MEN syndromes. Here, there is autoimmune activity against more than one endocrine organ, although non-endocrine organs can also be affected. These are also having other names. For example, autoimmune polyendocrine syndrome, polyglandular autoimmune syndromes, and polyglandular failure syndrome all mean the same. There are three types of autoimmune polyglandular syndrome: type 1, type 2, and type 3. So, type 1 is also known by an acronym APCED, APECED. Type 2 is known also as the Schmidt syndrome, and there is type 3. Apart from these, there is a similar syndrome called AIPGS syndrome, which stands for immunodysregulation polyendocrinopathy enteropathy X-linked syndrome. So let's have a look at these. The three main types of autoantibodies are directed to the surface receptor molecules, intracellular enzymes, and secreted proteins such as hormones. So the antibody may directly affect the hormone itself, or it may affect the intracellular enzymes which help in the biosynthesis of these hormones, or they may affect the surface receptor molecules which might hinder the feedback mechanism of these endocrine glands. What happens in autoimmune polyglandular syndrome type 1? As we call it, has the name APECED, APECED. So this is an autosomal recessive condition. It has three major components. chronic mucocutaneous candidiasis, hypoparathyroidism, autoimmune adrenal insufficiency. So the episode is a acronym for autoimmune polyendocrinopathy, candidiasis, ectodermal dystrophy, and it is also known as the Whitaker syndrome. So the acronym succinctly puts together the chief conditions. One is polyendocrinopathy, manifested as hypoparathyroidism and autoimmune adrenal insufficiency, and candidiasis. Okay, and the third thing is ectodermal dystrophy. So, what are these ectodermal dystrophic findings? Okay, we'll come to that later. Let's look at some of the additional manifestations which may also be there in APS type 1. They are type 1A diabetes, that is documented autoimmune etiology of type 1 diabetes is there. Primary hypogonadism, pernicious anemia, malabsorption, autoimmune hepatitis, ovarian failure, pure red cell aplasia, alopecia, and vitiligo. All these conditions, we know them to be autoimmune. And vitiligo even gives a surface marker to tell that the patient is having autoimmune disorder. So this is showing the constellation of symptoms of in type 1 APS. So in eye, we may have retinitis, blepharitis, keratoconjunctivitis, and in the mouth, there may be enamel hypoplasia in the teeth. So this is the component of the ectodermal dysplasia, which we see in APS syndrome. There can also be Sjogren's-like syndrome, oral candidiasis, candida esophagitis. On the skin, there may be arterial eruption, and vitiligo may act as a marker. Autoimmune hepatitis may be there, type 1 diabetes, exocrine pancreatic insufficiency may also be there, chronic constipation, chronic diarrhea, autoimmune enteritis, and also nail dystrophy. This is again part of the ectodermal dysplasia. Candida infection of the nails, alopecia, growth hormone deficiency, hypopituitarism, hypoparathyroidism, hypothyroidism, autoimmune pneumonitis, autoimmune gastritis, leading to pernicious anemia, gastric carcinoma also, ultimately asplenia, adrenal insufficiency, which is probably the most life-threatening of the autoimmune problems, adrenal insufficiency. Tubulointerstitial nephritis, nephrocalcinosis, hypogonadism, and candida infection of the vagina in the female. So all these may be seen in autoimmune polyglandular syndrome type 1. So this is a skin patch showing vitiligo, and this is the constellation of symptoms seen in autoimmune polyendocrine syndrome type 1. Here we are able to see in B and C oral and esophageal candidiasis. In D, we are able to see the ectodermal dysplasia in the nails. In E, we are able to see alopecia. In F, again, vitiligo we are able to see. And in G, we are able to see some arterial rashes. And in A, we are seeing aniridia. So these are all seen in, these all can be seen in autoimmune polyneuropathy syndrome, a constellation of autoimmune glandular affliction, ectodermal dysplasia, and the candidiasis. So what is the chronology of APS1? So candidiasis is the first to occur. It occurs in age less than 5 years. Hypoparathyroidism and hypocalcemic tetany and those features at ages less than 10 years. That's when it starts. Addison's disease, which I said, okay, could be the most life-threatening among these. Starts at less than age 15 years. All three main diseases thus take place within the first 20 years of life. So it will be diagnosed mostly in the pediatrics side of things. Accompanying diseases, though, continue to appear at least until the 5th decade of life. So we also have to be there for supporting the patient. but maybe the patient would already be diagnosed by the time the patient comes to us. So, as you saw, this is a very, very rare condition. It is autosomal recessive and it is suspected to be due to defect in the autoimmune regulator gene, AIRE gene. It's located on chromosome 21 and normally confers immune tolerance. The presence of all three components is not required to make a diagnosis. At least two components have to be present in an individual. Okay, coming next to autoimmune polyglandular syndrome type 2. Now, this is more common, the most common among the three here. It is characterized by the obligatory occurrence of autoimmune Addison disease in combination with thyroid autoimmune disease and or type 1 diabetes mellitus. Okay, so here diabetes and thyroid disease is seen, but autoimmune Addison disease has to be seen. Okay, so autoimmune Addison disease is seen, and the patient may also have autoimmune thyroid disease like Graves disease or and type 1 diabetes mellitus, insulin dependent diabetes mellitus. Primary hypogonadism, myasthenia gravis, and celiac disease also are commonly observed in this syndrome. So again, these are all because of autoimmune etiology. The most frequent clinical combination association is Addison disease and Hashimoto thyroiditis. Now this combination together is called as the Schmidt syndrome. Least frequent clinical combination is the presence of all three together, Addison, Graves, and type 1. Okay, so most commonly it's Addison and Hashimoto thyroiditis. We may also see Addison and type 1 diabetes. All three together is least frequent. Now, this one is an autosomal dominant syndrome, but it is having multifactorial gene involvement. Individuals are at a higher risk when they carry a particular human leukocyte antigen like HLA-DQ2, DQ8, and DR4. APS type 2 affects women to a greater degree than men. Coming to autoimmune polyendocrine syndrome type 3. Here, Graves disease and type 1 diabetes mellitus are seen. This is sometimes referred to as the Carpenter syndrome. As you can see, both of these could also have been seen in APS2, but APS2 has an obligatory requirement of Addison disease. Okay, and I told you Addison disease is a life-threatening problem. So APS type 3 is where the Addison disease is not seen. So it is a better thing to have. Coming finally to AIPGS, which is X-linked recessive due to mutation of the FOXP3 gene on the X chromosome. Most patients develop diabetes and diarrhea, and many die due to autoimmune activity against many organs. Boys are affected while girls are carriers and might experience mild disease. This is expected because of the X chromosome affliction, X-linked recessive disorder. So, this is the summary of the autoimmune polyendocrine syndrome. Type 1, we have any two of the three: adrenal insufficiency, hypoparathyroidism, mucocutaneous candidiasis, and obviously the ectodermal dysplasia. Type 2, we have to have adrenal insufficiency in association with either thyroid or diabetic autoimmune disease. In type 3, it is autoimmune thyroid or any other autoimmune disease except adrenal insufficiency. Autoimmune thyroid plus any other autoimmune disease other than the adrenal insufficiency, which goes to type 2. Also, patients should not have hypoparathyroidism or chronic candidiasis, which will make it go to type 1. And finally, APS4 is also there, which is a more loose term because any disease that doesn't fall in type 1, 2, or 3. two or more autoimmune disease of the endocrine glands, which is not going into type 1, 2, or 3. We could call type 4. So that brings us to the conclusion of these minor but very important disorders. Minor because they are rare, but important because they are life threatening, and we can save the patients by early diagnosis, by thinking, by having high index of suspicion for these disorders. Okay, we come across one endocrine and our mind should think whether another endocrine could also be involved in the manner of men or in the manner of autoimmune polyendocrine syndrome. And then we may try to screen for them and treat for them before they reach any life-threatening proportions. Thank you for your patient listening.